Hi and welcome to Lessons from the Grand Rounds. In this short video, I'll be sharing with you an interesting and a rare phenomenon in the field of hemato-oncology. So, mm, uh, I was fortunate enough to see two cases during my first year of residency itself, and I'll be sharing these two cases with you, and we'll be discussing some key points and what exactly this phenomenon is. So the first case is a 20-year-old male diagnosed as a case of B acute lymphoblastic lymphoma. The cytogenetics and the NGS at the time of diagnosis was not done. This patient was upfront treated with BFM2 2002 protocol, and post consolidation the patient relapsed. This patient is referred to us, and he receives the reinduction chemotherapy in the form of hypermini CVDA with inotuzumab. And now post that, on day 27 post therapy, he presents to the emergency with bony pains, back pain, shoulder pain, and generalized weakness and low grade fever. So the assessment for the bone marrow is due on day 21, day 28. Since the patient was admitted, a bone marrow evaluation is done, which on the aspirate there is a reporting of around 46% atypical cells. So a flow is run, and based on that, on the flow markers, the diagnosis is acute myeloid leukemia with monocytic differentiation. So this was quite strange, that a primary diagnosis of BALL, now post some reinduction therapy, now the patient is actually characterized immunophenotypically. First thing is that as a case of a relapse or refractoriness in the form of a different lineage type of acute leukemia, right? So let's discuss the second case. Second case is a similar 22-year-old female, primary diagnosis BALL, and during that time initially cytogenetics NGS not available, patient receives BFM, and then patient relapses during the maintenance phase. The patient is referred to us. Patient receives similar hypermini CVD plus inotuzumab. Patient undergoes into remission, and then patient is treated with CAR T cell therapy, and 6 months post CAR T cell therapy patient is almost asymptomatic, but the bone marrow shows around 18% atypical cells. Again, a flow which is done is suggestive of acute myeloid leukemia. So in these two cases, to understand these two cases, I'll just brief you about what are the types of acute leukemia. So we can have acute myeloid leukemia, acute lymphoid leukemia. We can also have we can also have acute leukemia of ambiguous lineage, where we'll have acute undifferentiated leukemia, which lacks a clear lineage commitment. And the second component or subtype of an acute ambiguous acute leukemia is mixed phenotype acute leukemia, which can also be bilineage based or a biphenotypic based. So what both the cases you have seen is that there was a switch of lineage from BALL to AML. So when there is a switch of lineage in the form, the most common switch is from BALL to acute myeloid leukemia. So switch from one lineage to the other lineage while maintaining the baseline cytogenetic and molecular abnormality is called known as the lineage switch. Very much rare, and the most common switch is between BALL to AML. So in both the cases, we ran a NGS post the second relapse or refractoriness, and we found out that both the patients were MLL or KMT2A gene rearrangements were seen. So there was a very good blood paper of June 2025 where Dr. Silbert was the main author, and he has also done a lot of work on almost 75-90 patients of lineage switch, described all of them and studied all of them. And it is said that increased use of immunotherapy is one of the risk factor for the same, for the lineage switch, and this is due to the clonal evolution of the leukemic progenitor cells with lineage plasticity. So when they analyzed the 90 patients with the lineage switch, they found out that there are a few particular or specific cytogenic rearrangements or abnormalities which are common in these patients. So the most common cytogenic rearrangement was the MLL gene, which is the mixed lineage leukemia gene, which is located on the chromosome 11, which is currently now known as the KMT2A, which is K-specific methyltransferase 2A rearrangement seen in almost 65% of the patient. The other cytogenetic abnormalities were CDK and 2A, PCRABL, TP53, IKZF1. These were the common cytogenetic abnormalities. The other thing, risk factor which was associated with the lineage switch was a proximal immunotherapy, which included either blinatumomab or inotuzumab or CAR T cell therapy. The median time they have described from the immunotherapy to the lineage switch is only 1.5 months, and the lineage switch from the date of diagnosis to the lineage switch was approximately 14 months. Very rare phenomenon, and this was all about lineage switch as a phenomenon where patient switches most commonly as in BALL to AML, and this was all in brief about a lineage switch. Thank you.